This is a podcast where experts in movement and life tackle current concepts in health and wellness and use science and evidence as the foundation of how we discuss each topic. This is not medical advice, but a sedentary lifestyle is much more harmful, so we should move. The Motif Experience, where movement and life come together. I'm your host, Dr. Tyler Cuddy-Ford. On this wide-ranging podcast today, we have Dr. Jeff Houck. He's a faculty, PhD, biomechanist. Interesting topics today about primary care, promise, patient-reported outcomes. True innovator in practice, but also a true researcher. So I don't know how many articles he's published. I don't know, maybe close to 100. So we're really excited to have him today.
The video for this podcast recording will start around the 7-minute and 30-second mark if you're on YouTube or other video platforms. And you'll also notice a hollow tapping from Drs. Houck and Cuddy-Ford when they get a little too excited during the podcast. Enjoy!
To tear down the past, it's harder to build the future, right? Because you don't know what it is. But it's easy to look back and say, oh, that was wrong, this is wrong, we should have done this. Right. That's like so cheap. It's like such a cheap shot, right? And what's happening now is like everybody's being like called out for something that, you know, it may have been bad taste or something, but it wasn't really the worst thing. And going back, finding this, BPS model, grabbing a hold of it, and there's all kinds of great reasons it was impossible to implement,
right?
And it made no sense at all. And to call us out, like, and us, because it's me and you, right? For not doing better is complete bullshit, because we were working our ass off to try to make things right. And so we, maybe we were stupid, but it was like we didn't understand pain in the same way we do now. It was that's new information,
right?
And so anyway,
I mean, really new. So when you look at medicine, or it's within the 10 years,
right? But you can also, but then as research goes, you could trace back that there were signs of that going on, but it wasn't prevailing thought, and so people thought that psychosocial issues were. They were secondary to the bio, and they were caused by the bio, because there was good data on if you got rid of the pain, all of the depression and psychosocial issues went away.
Right.
And so we all thought, well, that's a secondary effect, not a primary cause.
But we didn't know that the bio wasn't bio.
Right, that's right.
And so I think it had to be all of these things needed to happen in order for the current climate to say, hey, what about psychosocial?
Right. And then what is that? Can that really cause things? And then I do believe that the recognition that the placebo was so strong was a flag to everybody, because it kept coming up. Like, you'd have these great design treatments, and then basically the placebos would be as good, and then you'd be like, well, how can that be true?
Well, what about, in the same, I guess, theme, reading some articles around. So even a randomized controlled trial, let's disregard the placebo. People still are getting better. So it's an average, of the mean that when you look to see if this treatment.
So you're talking about regression to the mean.
Yeah, but you still have pick a number. 30 or 40% of the people aren't getting better.
Oh, even in a successful clinical trial.
Yes, that's what.
Because it only addresses.
Even in a successful clinical trial.
Yeah, because it's on the mean, the average, not the individual.
Yes, not the individual.
So but EBP refocused the statistics, basically on effect size, percent, MCD accomplishment, this kind of thing. So that issue got recognized when Sackett and those guys came on board, and EBP became a thing, and that's like starting 94 to 99 when the first low back pain guideline came out, right? And that was, there was a whole issue of JOSPT that refuted it, based on, just pundits, basically, with no data, just because chiropractic won, over everybody else, right?
Well, I remember you and I think read that together at Iowa in '96.
Yeah, right.
I think, right. Is that right?
That's about right.
Yeah, and that
was published by the Agency for Healthcare Policy and Research, right?
It was a red book, right? Or
it was orange.
It was orange. Yeah,
it's orange. They still may have it in the.
Okay, yeah. I remember having discussions with you. And I was new. Shout out to Iowa. So I got my shirt on. I don't know if you're filming.
Are you recording already?
The cameras are giving me error readings, so I'm trying to figure out what's going on with them.
Oh,
I'm recording.
Is it the new card?
It might be. It's giving me error readings with them in, so...
Just put the old ones in.
I might just put the old ones in.
Yeah, just put the old ones in.
Okay. Anyway. You guys are doing great, though.
So I don't know. But, so we're just going to bullshit for an hour? Is that what's happening?
Mm-hmm. You already started.
This is just gives you a little framework. So, and she can edit all this out. But
I probably won't.
We've been interested in podcasts for a while.
Right.
And then just not able
to
pull it off.
Right, this is the Josh Rogan style.
The Joe Rogan.
The Joe Rogan. I love those. They're funny. They're absolutely fantastic.
They are rich with information.
Yeah.
So I wondered if we could do something like that, because the genesis behind the podcast was to help our alumni. They can't they can't keep current. Here. They can't get here.
Right.
They're taking their charts home, so they're not able to pull up all the newest research and all that kind of stuff. And I thought, okay, well, let's get geeky about a podcast, and then we can just talk about research.
Right.
But then I thought, after watching successful podcasters, that's not what they're about.
Right.
It's about a relationship, about these adult conversations.
Right.
But
they still have.
No, but you were going to say it. Yeah. But in between, there is richness around
they
content.
Get really
they get real specific and personal.
Yeah.
So I thought, that's what, when, Dan was number one, then Andy's next week, Kim's the week after next, right? So
Kim will be great.
She'll be great. So the idea is to intersperse. So when we did just like what we talked about, health care policy and research.
Oh.
Which
one?
The health policy research.
Oh, okay. Yeah.
And then we dove down a little bit.
Yeah.
Right, and we talked about that, and then we'll go out.
Yeah,
something else will come up. And then something else will come up, and then we'll say, "Oh my gosh, this is what influenced me," and I'll ask questions to you around what why are you I'll prime you. So
okay.
So why'd you make the switch?
To psychosocial.
From bio to psychosocial.
Let's talk about psychosocial, because I just had it was funny because there's some vanity. I have to admit to vanity.
Yeah. See, this is good.
I know. So because it's like I'm not. I just am not.
Do you have the batteries in?
Yep.
Yeah, you do.
Okay.
I'm not doing all the stuff that I thought I would. I really love engineering and the biomechanics. I mean, it's magical to me because it fits everything.
It's still fascinating to me.
Oh yeah, and I've got a new thing. I think I sent it to you. It's like I'm super interested in this idea of organism.
Yeah.
Like instead of teaching biomechanics from the perspective of a machine.
Yeah.
You can teach biomechanics from the perspective of an organism, meaning that after you kind of to add this in, it's another layer, right? So,
or as an example, a bird's bones are hollow.
Right.
Right. So actually, I think some of the engineering principles have come from the organism.
Oh yeah.
So honeycomb structure. I mean, you go down the list as far as what.
Yes.
And so I don't think that's a stretch.
Well, see, there's an article today. I gotta watch this video. I'm addicted to these videos in the New York Times. So they have the science guy.
Yeah.
He explains something in nature.
Yeah.
So the one I saw this morning is how suckerfish.
Yeah.
What the mechanism? They figured out the mechanism of how they stay on a whale.
Oh, all right, sure.
Because basically they're this little tiny fish, and the whales are diving and going at really high speeds, and then there they are stuck to the side. So I love that stuff, right? Because it's and then the other one that was really fascinating is how does a mosquito land on you?
Okay.
Because it's flying in, you're moving, so relative speed is super high, and then it's not landing perfectly, so one comes down, cushions the shot. So they're thinking if they studied that, then they could figure out how to get a lunar module to land on the moon better, right? Because it's just coming in, right? And so anyway. That kind of stuff's cool, right?
Yeah, no, it's cool. I remember at Nike, we took a trip to the polypedal lab.
I know, that's funny, right? That was awesome.
At Cal, and it was oh my gosh.
With the cockroaches up on
cockroaches,
their high feet.
Cockroaches, and things running across
that was
the gel and
how everybody's
treadmills.
bipedal, like how there's the inverted pendulum model, like works for cockroaches and crabs and humans all the same. That was cool. But that's mechanism, so it's organism. But see, what I was really meaning is like you and I are in homeostasis all the time. So instead of us, kind of fitting like the current state of art, like when we think about, how we're doing treatment, we were in this zone of biomechanics. So if you have, I don't know, these malalignments in your back on your spine, then it's fait accompli. You're going to have pain, and so until those are fixed, it's not working. So the alternative is to say, well, there's adaptation, and they're adjusting to all of this. And so, well, then what it should be is the basic science then that the students learn is like, how do people adjust?
Yeah.
And what is the adaptation capacity, not just the capacity of the fixed system. So how much can it adapt? So there was a new model that just came out on osteoarthritis for the knee that shows that if you stay running and all that, you get this kind of increase in cartilage thickness that actually protects you as you have OA.
As you age, right.
Right, and so this whole dynamic of like how the primary disease, not just because like OA is interesting.
So how new is that? Because we've done, because isn't that true though, that one of the theories around even if you had significant OA, just to be able to get up and walk and the compression, and the movement of fluid and all that kind of stuff. So that's been known for a while.
Well, it's not been known. It's been theorized.
Theorized for a while.
But people never knew. Like you never knew if it was secondary effects or primary effects, right? So because you could have just where you started, right, or your tolerance, right? But and so having it in a model that's transferable to like people, like and to students, and say, okay, here's a model that can be, in a real practical way you can think about and apply to clinical care. Right, or to just put it in a like new person's head, right? That there are these cycles that are regenerative, and in addition, so you put that on top of like a cycle that's degenerative, right? And now you have two interacting, cycles that are happening, and then that's a way for people to say, okay, maybe we can tap into the regenerative or the regenerative cycle,
that different cycle, right?
And defer this decay that's occurring, right? And but it's until students or new people, because they have a hard time like concretely understanding, how things can come back or be okay when they learn, okay, here's all this math that says the inevitable is going to happen. They need like a concrete like thinking mechanism that says, here's how the body would, deter that. Right, so that they can then tap into something that's real instead of just saying, hey, if we do this therapy that we really have no idea what it's doing, you're going to be better, and look, it worked.
Right.
And so I must be correct, and the theory's like way out of whack.
Right.
And I think that's kind of where we're at now, is there's like all of these things. If we just, dry needle you and
red cord and
put tape and strain, counter
restoration.
Strain. And there's this,
By the way, we're going to do a podcast on that too. It's the Mythbusters idea. And so, having fun with it, but at the same time highlighting some of these I don't know, absurdities, that our profession is kind of in right now. And I liked your comment, and I've learned a lot. So this is Jeff Houck. And I met Jeff 1996. So
yeah, it's true. Your first
24 years ago, and so we got our PhD in the same lab, applied biomechanics lab at the University of Iowa, and so he's here. I think some of it will be about his journey. He's our director of research, and so from hardcore engineering biomechanics to now. I'm more psychosocial. So
I'm doing mostly psychosocial stuff with dabbling.
That's kind of where we're at. But now what we were just talking. So that doesn't matter.
We're talking about we were talking about organism versus, and then you got into myth busting, right? Yeah. So myth busting's hard, I think, because
that's where I was going to go. With
models.
This. Well, I was going to go. You have always been an advocate for not just myth busting.
Right.
But providing a solution.
Right.
So don't just go in, just like what we talked about before. Don't go in and just bash everything without giving a solution. I think that's an important piece. So I think when you started here 8-9 years ago,
it's true.
That was important to me.
Yeah.
When how are we gonna? So Jeff helped me start the program, and how are we going to teach our students differently? And not just myth bust,
right?
But provide frameworks for them to understand. And I don't know what we were talking about organism. Right? That's
same.
It's the same. We're trying to provide them a framework for why are the interventions that we're having you guys do. Why do they work?
Right.
So the physiological underpinnings of these ideas. I think that's important to us.
Yeah, thank you. So, to me, one of the revelations in my life,
Oh, here we go. Yeah,
this is a good one, right?
Yeah, that's good.
Was, thinking about the truth, right? Basically, you did the same thing. A PhD is like a commitment to truth. It's not monastery exactly, but it's close because nobody does them, and they're a lot of work, right? And so, one of the things that was interesting in there was the recognition that an RCT, everyone's always, our gold standard for an intervention, right, is a randomized controlled trial, but it has a very hard time proving a negative.
Right.
Because it can really it just does two comparisons, and it always proves one is better than the other, or they're as good as each other.
Right.
But they don't prove a negative. And I think there's some new models out right now that are trying to do that. But the science can't prove the absence of something.
Right.
Right? And that's like very philosophical and everything, but at the core level, it's like you can't really discount stuff. And I think so that's the first thing, is it's like, so it's people kind of recognize that, I think, at an intuitive level, so they always are replacing negative findings with explanations.
Right.
And so that's one thing. And then the other thing I thought was, people do stuff like all of the different treatments that people do because they want to help people. And it comes from a real sincere, positive, kind of...
Yeah, I believe... Yeah, I'm with you on that. I think that's
people,
true.
PTs are, passionate, and that's what I like about the profession, really. You can go anywhere, and the people believe in what they're doing 100%.
Right.
And they are, sincere. And so I think myth-busting is interesting because they're adapting it because they're needing a solution for patients' problems, and they have patients in front of them that need those solutions. And so they're 100% committed to this, right? So,
well, don't you think? So we did primary care. So you and I and Dan really pioneered this idea together. And so what was interesting to me is a lot of things, but when a physician comes and speaks to someone that has back pain.
Yeah.
Okay. And let's say acute back pain.
Right.
And so they have an episode, and so the tools that the physicians have.
Right.
Are really three things.
Right.
So, and I love the fact, sometimes I think PTs give physicians a bad name, a bad time, because they maybe don't understand their profession, whatever the reasons might be. But I thought it was gold when, when they would say, I want the patient to be better after they leave. So it's like, how perfect is that? Right? That's what we all want, right? So, but the arsenal they have, okay, let's give them some muscle relaxants, right? Because you can see that they're all jacked up. All right, let's give them some pain medicine if they need them.
Yeah.
And then, let's get some anti-inflammatories because there's probably some inflammation there. So that's the arsenal they have. And then when we meet them, we have a different bag of tricks.
Right.
And so we come in with some different types of training.
Right.
And now all of a sudden there's a different model.
Right, because they want to tap into anything that will help the patient.
They do. So it's just so this in theme with your the conversation earlier. That's exactly it. So physicians are the same. They want to tap into how to get the patient better.
So I one of the things I couldn't support that important message more, because it's like when we were in there, that happened, of course, but then there was also, I was on these doing this work at U of R, University of Rochester, in Rochester, New York, and one thing that happened there, we put in a grant that we didn't get to the Agency for Health Quality and Research, and it was about reform, like using patient-reported outcomes to do some reform or whatever. But in that literature, it's quite clear that there's all this information about primary care and how there's too much pressure on the providers and all this kind of stuff. And it's extensive, the burden and the burnout and all this kind of stuff that's in primary care, right? But what was really cool was that in all of that, it's still, the data shows that if a provider believes that patient care will be impacted by a burdensome...
Another intervention that's been top down.
And it's burdensome to them.
Yes, it is burdensome.
They will 100% adopt it.
If they think it's...
If they are if they're convinced that it will make a difference in patient care. And so to me that was so inspiring because it's in spite of everything.
Did that come from Promise?
No, this was that data. That data's...
That's been around.
It's in the reform, like health reform data that you can find it that'll say, and these are physicians, that they will add it on no matter what if it really makes a difference for patients, right?
Got it.
And so that's really cool, right? And I think, in my personal experience in seeing providers, they really are current, like, the new blood pressure guidelines, they're pushing, lower, kind of blood pressure guidelines for hypertension, which is amazing, right? And
even mild hypertension, right?
Yeah, and that's just the new thing. So you're getting more drugs, same with the pre-diabetes programs, they're really on board with it, they're aggressive, right? And so, I see them really as, kind of champions, really. Yeah. And I have, after, reading that literature and being in primary care, I have a lot of empathy and compassion and, wanting to walk with them. Yeah. Because it's a great mission, and I think it fits physical therapy perfectly.
I'm with you too. I mean, that was, you and I practiced a long time. Yeah. In a lot of different settings. And that was probably the most fun setting that I've practiced in. So it seemed like we made the largest impact in that setting.
Well, I think, let me ask you, weren't you surprised at how, to me, that was, I went in thinking, that this engineered idea of what we could do in primary care. Yeah. Decrease imaging, stop injections, do better diagnosis. Right. I left with thinking that was such a small part of the impact we had.
Yeah, that is true.
And so I thought that was really marvelous because it's like experience. Yeah. You need experience in the environment to really know where the advantage is.
That's exactly what I was going to say. We've never been there other than some readings, like you said, and then maybe as a patient.
Yeah, exactly.
And so we didn't really know, what was really primary care was really about from a healthcare perspective, and it's amazing.
No, and I agree with you because it was so, we had an idea, and being with them, their avalanche of work that is, impossible. Right. Every day they start the day knowing they will never accomplish what's in front of them.
It's just like PTs; their charts are just this high, waiting to get done.
So. Yeah. So I don't know, like that was that made me really passionate about stepping in there, and then the second piece was just when you look at the data on how many people come to PT that potentially could benefit, right? Right. And then you couple that. That's 10%.
So that's striking. So tell us a little bit about that.
Well, there's a brand new paper from I only know the last author, not the first author, but Ann Thackeray from University of Utah. Yeah. They just put out this brand new paper. It's fantastic, and it talks about the different barriers to attending PT, but that there's a lot of important information in the paper, like the lack of people coming has to do with transportation, which is a real thing, all across the U.S., but the whole West has this problem larger in Midwest. Right. There's, it's mostly rural. Most of America's rural. Yep. So it's like, if we really, so that's one thing, and then but statistic at the end of the day is like 10 or 11% of people are accessing us. So we should, if we're really thinking in terms of health and public health, right, which is, I know public health is a big term, but it's if you step back and say, look, I got into this profession to help people, well then, why aren't we defining that as like eradicating a problem? And that's always been my thinking, is it's like if you look at like like total joints, for example.
Yeah.
Total hip replacement really eradicated, this idea of end-stage arthritis, which disables 50-year-olds.
Right.
If there isn't a total joint, right? Because the alternative is a hip fusion, which you can't do much with a hip fusion, right?
Or no surgery and limited activity.
Exactly. So the alternatives are horrible, right? And so I think we would do better to get on board with how can we eradicate problems and think in these big terms, because we wouldn't get caught up in treatments that then now only serve very few people.
No, I like that at all. Or treatments that, like what we just talked about, treatments that actually don't help.
Exactly, because for reasons of all kinds of different reasons, right? So, but it's like that focus right there. If you just start with that focus all the time,
I like that a lot.
Then the energy that we have would be like go to these places that we can have a bigger impact.
So how does promise fit into that? So what is promise? Part one, and then how does promise fit into that?
All right. Well, can I just go back on why I changed to promise? Because here I am doing all this biomechanics, movement analysis stuff, and when I came here, I couldn't really be in the lab all the time for different reasons, and so then what got me into promise is I want to give a shout out to Judy Baumhauer from the University of Rochester.
You should, yeah.
Because essentially I ran across promise in 2009, and thought it was a complete waste of time because it would never evolve. And then I was doing a module for my EVP class here at Fox in like 2014 or something. And then I ran across it again. I thought, oh my God, this is going to take over the world.
Right.
And so and then I basically 2015 I met with her, and then for the last 5 years we've been publishing all kinds of papers on promise. Right.
Yeah.
So what's promise? So promise is like a new patient-reported outcome, which doesn't sound exciting, and if you should not be excited.
So don't turn this podcast off.
Right, exactly. But you shouldn't be excited about a new patient-reported outcome because there's like way too many of them.
Right.
And so, but what's unique about this is that it's person-centered. Okay, and that also doesn't sound exciting, but that's actually more exciting than it sounds. So we'll get to that.
Right.
And then the other thing is it's computer adaptive, and it's derived from both patients and providers. And so those are all. None of that sounds exciting yet.
Right.
And so
not yet, but
not yet.
It's coming. So because you changed me in an hour.
Right.
I mean, it was easy for me to make the switch. So
let me ask you. Because
a little more background. So what's the difference between promise and photo? Just for someone that might be used to photo and.
Right. Well, so promise is a measurement tool, and then photo is a company that provides, kind of a data set of. Hold on, I should have. Did turn my phone off here. Sorry.
That's probably a good reminder.
Yeah, right. So photo, I actually don't know a ton about photo, except that it's a company that provides, like, can you just put in on this section, like when you do it, like, can you just put what photo actually is, so that, Dr. Houck really doesn't know what he's talking about. Something like that, just from them, because they're like a company that's real. Right. So I think, photo is essentially providing a service to providers so that they can get their PROs done, and then they can get assessments that allow them to get paid, and they may use them or not for kind of revising their care. And they also do things like predict how many visits somebody needs based on these algorithms that they do.
Right.
Okay, so promise is patient-reported outcome.
Measurement information
system. I always get it's
that's
funny,
right.
but
it's I know.
So the idea though is it's a measurement tool, and the goal is to measure to evaluate healthcare across all diseases, providing agnostic, uniform assessments that can be applied across anything. So, for example,
any patient population,
any patient diagnosis, and any age.
Right.
So if you
any ability.
And any level of ability. So if you're really disabled, or if you're really a high level athlete, you use the same physical function scale for every person.
Right.
So that's not really possible. Like the LEFS does not work for that. Right. And neither does the OSWES-3 and all these things. Right. And so and that's still good, but not great. And so you have to you have to kind of start thinking about how measurement works before you start thinking it's great. Right. So So I think
it's still tapping into the geekiness that you have.
Oh, it
about,
does, totally.
About engineering and details.
That's true.
And
so
and measurement, right? So
so what convinced me is like, first of all, it was just like a cool tool. So it's like, let's just play it out though. Let's talk about something everybody's more familiar with. So let's take the SAT for example.
Yeah.
So if you take the SAT right now, which I actually haven't taken it, but I heard that this is working, so you can imagine it, right? So it's possible to get a grade on the SAT or on a test like that in 10 questions. You can get your whole verbal score, and I actually don't know if that's exactly true, but conceptually it's
like
true.
That, right.
Something like that. So essentially what it does is it takes all the items on the scale, puts them in hierarchical order, and then says, let's...
So this is the computer adaptive that you're talking about. This is the computer
adaptive component, right? So essentially if you're these 10 questions, like the hardest one's 10 and say the weakest one's 1, it asks you a question in the middle, and then essentially if you get it wrong, it's going to ask lower level questions, and then it's going to find a middle spot. And then if you get it right, then it brackets your knowledge base.
Got it.
Right, on the SAT. And the same thing happens if you're higher.
Right.
So if you do that 4 or 5 times, you already now know, if you do the probability math, you're already now, within 10% of your bracket in 5 questions.
Right.
Right? And so you can get to where somebody is really quickly as long as there's a lot of validity in the items.
Right.
So now every single question you ask has to be, intensely kind of developed and validated so it can work across all these different people, right?
Yeah.
And so the things in the promise, so that's a concept. So this computer adaptiveness is what makes it so there's no floor and ceiling effects in any of the measurements.
Right.
Which means that's same as saying you can measure somebody who can barely breathe. It's the same scale you can use for an NFL athlete because it's bracketing all these things. And that depends on the items.
Right, the type of question that they're getting exposed to.
So then you got to have good items.
Right.
So how do you get good items at that level? So in 2000, they asked all these items in the 2000 census for the U.S.
Yep.
And so then over 12 years, they did cognitive interviews and all this kind of stuff and ran data on all these items. And essentially they developed these new scales, right? And so they measure, physical function now it's on its 3rd iteration and has 200 items that have been developed that measure 3 standard deviations of the U.S. average in both directions.
Right.
That's crazy. And what they've done is mapped how much of the function we were actually capturing on our scales we use now. They only capture that because that's the whole space of functioning, right, from athlete to low level.
Right.
And typically an ODI is only capturing 10% of that range.
Right.
And then we're making all kinds of judgments about whether it works or not, right?
Right.
Okay, so let's just back up. So it's they used the 2010 census. So how many data points were in the validation studies for the first PROMIS scales?
Yeah.
They have 20 or 17,000 subjects in the first iterations of the physical function scale.
Right.
That was validated. So there isn't any legacy measure like ODI that was ever validated with more than a few hundred or maybe even less patients, right? And so it's a completely different equation for this, and 90% of the legacy scales were developed by providers with no input from patients.
See, I'm understanding why you like it now.
Right, so that's good.
Because when you described it to me, of course, we didn't get into that detail,
stuff,
which is fine.
Yeah.
But the power in the output for me was the game changer.
So which output is just the computer adaptive part?
Yeah, the computer the results of looking at their score and knowing exactly where they're at.
Right.
That output.
Right.
And it's just for me, it was well, how do you do that?
It's crazy.
In 4 questions, how do you do that? So the physical function, 200, a bank of 200,
right?
That you answer within 4 to 6 questions.
2 points, 2% of the scale, you can be accurate, right?
Right. So that's pretty amazing that you would know and that you could see a change in a treatment session.
Right. And so there's a couple questions that were important that as people look at PROMIS, we talk about PROMIS too much, right?
Right.
But essentially, the bottom line is there's enough data right now that we can say with high level of confidence, not 100%, but a high level of confidence that, and most problems in the body, that these person-centered measures that ask nothing about the disease. So if you have, you're going to use the same measure for low back pain as you do for the knee. So not only can they frame all this, they can, you can use the same one for both problems. And you're like, well, how does that work, right? And what they're doing is they're just asking about function rather than function particular to the disease.
Right.
And so there's always worry that, you can change somebody's back pain, but you don't actually change their overall function, but they just feel better in their current functioning, right? And so people worry about that. And so at this point, there are a number of studies that pit disease-specific scales against these kind of agnostic scales that never mention the person's disease. And essentially they perform just as well in terms of responsiveness and picking up change and showing improvements in people. Or better. And then if you flip it around and say, like, the most common thing I get when I go around talking about this to different clinics is, we just can't get validation for treating people. They're better. They're like they have an ACL and they're better, but they're kind of topping out on the LEFS, but they still have goals and stuff like that. We can't show change. Well, of course you can, because it has a ceiling effect. Right? Or a floor effect too, right? And so, but PROMIS doesn't have one. And so, basically, like a good example is for the U.S. average is 50 for everybody, but young people that would have an ACL injury, their average is 60. They should be one standard deviation above the U.S. average. And so, right now, if you had a ACL person that were at 55, which is pretty good functioning, right, you could make a case that you need still need more. You need some more visits because they should be at 60. Right, if they're an athlete,
or even higher if they're a competitive athlete.
That's right. They could be. You could want them to be at 65, and you could say, I can measure it, and I can show change, and I can pick that up. That's possible with PROMIS. That's impossible with any other measure you have.
So is it fair to say that PROMIS was the flip for you from biomechanics to psychosocial? Because you and I went to Africa, we did a barefoot study. I mean, we were
still going down biomechanics.
We were still going down biomechanics. You had
fluid dynamics. We're going to get the
you had to encourage me to do some Achilles tendinopathy, research. And this was, I'd say, about the same time.
That's true.
And so we went a little bit deep on that. We did the clinical practice guideline together.
And
then and we were trying to understand the capacity of the tendon. So that's biomechanics and geeky. Right. And so, but then at the same time,
it was two things. It was that it was the first thing was primary care.
Okay.
Because it really brought home this idea of public health and stuff like that, and a refocus of PT. We're kind of completely in the wrong direction by being focused on specialized skills. And I'll just kind of keep hammering it. It's like, trigger point, this like dry needling stuff like that. It's off the railroad tracks in the wrong direction from my perspective. And so being about public health things, because that's what the healthcare needs right now. It needs champions that can do things across the spectrum.
You probably know. I mean, I left Nike because of that.
Okay.
Right, because I was interested in real health change. Not necessarily, sports or an athlete that had this, small little injury.
Because it's really like micro, it's micro. The shoe,
it's micro,
the foot,
but the overall health of, the population here was important to me.
So it's good. It's like and it speaks to just like frame, right? Moral frame and all this kind of stuff and character, but. So that was the first thing, was like, look, what does the world and people need, right? Because, I mean, that's where you want to go, really. And so the second piece, though, the second piece was, it was like, I kind of really didn't get fascinated with PROMIS until I saw what's happening. And so I would say that the first step was when all these PROMIS scales, and basically it was only physical function and pain interference. And depression.
Initially, when you were looking.
Was initially what we're looking at, right? And so, but just kind of back up a little bit. But what's interesting to see is so the Oswestry asks 10 questions, right? And in 4 questions, you can find out the same thing. right? So what it means is you can ask more things.
Right.
And that means you can measure more domains. If each promise scale only needs 5 questions, and say you have, and each promise one takes under a minute, so you could ask 5 different questions if you limit patient burden in filling out questionnaires to 5 minutes.
Or mostly under. Yes.
That's right.
Less than 5 minutes.
That's right. And so you could get a lot of information about a person, right?
5 domains.
That's right.
So pain interference, physical function.
Mm-hmm. Now, so then where do you go next? Because basically that's all we've measured.
Right.
And right now that's all 90% of people are measured. So now it's an open question. What else would meet patient needs? What else do patients want? What do providers want?
Right.
What do people want to measure? Because basically what we end up measuring, we're going to end up treating.
Well, I remember one of the providers, and he just kind of asked that we go into the room and address this question. Do you remember? He says, I want to know what your fear is.
Oh, right.
Right. And so I don't know, did that influence, this idea of self-efficacy and those things, these other, where you're spending a lot of your time now?
So for sure, this psychologically informed physical therapy stuff sat there.
Right.
But that wasn't enough because, see, at that time we were still not convinced that it was 100% as important as we thought. It had
value that we thought, right.
The same level of value that we thought now.
Right.
So at this time, what was really impressing me is when I worked with orthopedic surgeons, that they would tell me behind the scenes, because they're publishing these studies on, promise and stuff, but they would say, I don't know about promise.
Right.
And I said, why not? And they'd say, because I'm really just treating the foot, so I want the foot to get better.
Right.
So I really like the disease-specific scale because it's more direct to my treatment.
Right.
And I was thinking about that for a minute, and you think about that for any amount of time, and you start to think, wait, that's off the railroad tracks. If a person's coming to you, your first, obligation is to the person.
Right.
That means their overall health should be number one. Their small problem they're having is the foot, like their heart, the things that are going to kill them, right, should be your primary focus. And then, other things, you can take care of too, but that you should be focused on the whole person.
Yeah.
So to me, when I started hearing this pushback, and some of it quite strong, I thought, wait a minute, why aren't you prioritizing the person-centered measure? And why are you spending so much time, kind of loving this measure that you can change better because it's just to the joint that you care about?
It's pretty micro.
Yeah, it's too micro. And it's like, I think, well, that readily there encapsulates what's wrong with us currently.
Right.
Specialization is only as good as it augments the whole.
Yeah.
Right? And so that's a big problem.
Yeah.
And so it made me start to, so this is why the person-centeredness became like a mission. And then I'd give a shout out to Cleveland Clinic, who, asked us to come speak. And, Mary Stilpin there, she also became like, I think she wouldn't mind me saying this, really passionate about this idea of person-centeredness.
Yeah.
And I think it's exactly where we need to be, because that's why we got here. We didn't get here to be good at back pain or good at ankle problems. We came here to help people. And that's how we started, and that's what we're really about in a technical way. And so Promise holds us to it, because it's a person-centered measure, and it holds everybody to it.
Right.
And so in a way, I started thinking about, Promise, that's the other piece of it. It could really unite providers across the spectrum to all be focused on the same thing.
Yeah.
And wouldn't that be brilliant? Wouldn't that be amazing for the patient to have everybody using the exact same metric and trying to change the exact same metric? It could be, a uniter. And there's other things that could, so I don't want to get too, this is a miracle thing.
Philosophical.
But, I mean, it's really cool. Like, it could happen, right? So there was, so that was happening and like shifting. And then they were having these experiences in primary care.
Didn't University of Rochester change some of the practice patterns based on results of the Promise?
So I don't know how many have changed. I know that Dr. Baumhauer has.
Okay, let's and
I know that some patients have,
others,
and so what they're doing is what they call clinical comparative research, which is like non-randomized comparisons of data now, and they're using non-randomized comparisons of data based on the Promise registry that they have that's going on to kind of modify care.
Right.
And without getting into it, it's really needed, because essentially we can pull up data that suggests that care is too non-standardized and the effects are not good for patients, basically. Right. And providers can't really see it now. And it's data mining and this big data are going to fix that, right? So
we talked earlier about providing a solution to, other than just myth busting.
Yes.
I don't know.
So but you asked me a question about promise, so I wanted to get to that, right? So the big thing became so that's all of that's good but not great because it just still focuses on physical function and pain. So then what I started seeing is that with the psychosocial stuff, and this is what got me really passionate about it, is we need psychosocial. We need to be more psychosocial in our care to be relevant going forward. And my just general hypothesis is the reason we're only seeing 11% of the pile in terms of people we could access and help is because we're not focused enough on psychosocial. So that's the positive side. If we became more focused on psychosocial and took a more positive look at public health,
or just more focused on public health,
but
or population health.
Well, because psychosocial is where people don't want to come for this kind of exercise special thing that we have, but they would come for a behavior change, psychosocial version of that.
So in the behavior change literature, in the psychology literature, so they see more percent of the population that need it.
100%.
Okay.
I mean, why right now one of the biggest kind of current modifications of primary care is having a behaviorist study every single
that's not my question. So because you're arguing that if we highlighted psychosocial, we'd get more people.
Yes, that's a hypothesis.
Yeah, a hypothesis.
That's an argument.
It's an argument. Yeah. So but couldn't you tell then in another segment of the population, so meaning those that need behavior health,
right?
So what percent of those are accessing that group?
So you mean like what percent of
the population you said
are going to behavior for change,
even though they could qualify? So similar.
Right. So what I would say is like right now,
because that could be your comparison.
So I don't have the answer to that, but what I'm using to justify this, is the idea that when I talk to behaviorists that are in primary care, I hear them talking all the time about things that we could be good at.
Yeah.
And so the patients that they get sent to, and that they also probably could use our help with, right? And see, that's where I'm making my argument, right? I see the opening there because
I'm not disagreeing with that. There's a big opening for us to fill voids in these population health. Diabetes, heart disease, obesity, these things that we are trained
start with
to
chronic
help
pain.
Right.
Start with chronic pain. So they're going to behaviorists. Well, if we had really good behavioral health training, why wouldn't they come to us?
Right.
And then then with some help, sometimes they would go to them, but they'd come to us.
Yep.
And we could do some of that because they actually need help.
Because
see that was another thing that I'll just this is a good kind of answer to that too, because when the first promise scales came out, the very first proposal we were going to do, because we had depression in addition to these others, we put a proposal in that we also didn't get, which was to flag depression and then hire a social worker to treat those people, and so it was to be automatic. And you know what the big barrier was in terms of implementing that? So these are all across orthopedics. These are orthopedic surgeons that wanted to flag depression and have it treated irrespective. They would just have a trigger would come in.
So now that's not the problem.
Yeah, so they would be addressing it. They want to be psychosocial, right?
Right.
And so the big problem was that there was no one was willing to do the service because they're tapped out.
Oh.
There is no resource, right? Because social work, behaviorists, psychologists, completely tapped out in other services, and so providing this overburdened them, and they couldn't pull it off. Right. And that was
that's interesting.
Right. And so that was telling to me. And then as we go, like when our experience in primary care, we talked about who they saw.
Yeah.
They mostly see people that are severe,
right?
Because there's not enough of them to see everybody else, and they're completely tapped out,
right?
Right, and so you could say, hey, we're not trained, and we want the specialists to see them, and so we're going to stay in our physical bubble, right? But essentially, the need of providers right now, they need more psychosocially trained people, period, in any element. And so if we were able to do more of our physically related psychosocial work, see, then we could take some burden from them, and then they could expand more.
I guess I could argue that they need more people in population health, or public health, or rather than these specifics of that, which would then encompass that particular population.
It could. So, but that's kind of what I was thinking in terms of, and then if I look across like my dad, or family members or people who are sick, right? And you go through their encounters, or you talk to people who your friends who went to PT.
Yeah.
Like I had one. I was at a party once, and one of my best friends had a Achilles tendon rupture.
Yeah.
And he said, everybody had been to PT. They said, how many of you do your home exercise programs? And then everybody's like, no, none of them ever do their home exercise programs. So like, why do we go to PT? And it was this big question, right? And it's like, so if we're not psychosocial, I mean, we're really failing, and giving this regimented, perfect world kind of and I'm sure the home exercise programs are amazing, right? And so, but nobody's doing it. So,
and we've known that for how long?
Yeah, forever. Forever.
Yeah. Because I would always know if they did their homework when they came in the next week.
Everybody does.
Yeah, that was 25 years ago, 30 years ago.
But we still keep doing the same thing. There's a definition for that, right? You do the same thing, it doesn't work over and over, right? Right? And so I think, being psychosocial is about like, okay, what will you do? What are you willing to do? And then I don't know.
That's a nice link I hadn't really thought of. So, which is, now that we're, talking about it, that really is, a more of a challenge than for PTs to think about how, because we all think we're affecting change, and then and maybe for those that are coming, but then for those that for whatever reason don't want to come.
So let's just do the math, right?
Yeah.
So we see 10% of everybody.
In Oregon it's 15, right?
So let's just be nice. What percent of those people actually do stuff that we recommend?
Yeah.
Right. And so it's like
So
how many people are we actually affecting?
Let's say 50. Let's be generous and say 50% of the 10%, right?
Exactly.
Doing something.
Right. So if you so to me, like getting all this, it was like a no-brainer.
Right.
If we just stepped in and started saying just being 100% psychosocial, and then once, what would that yield? And then basically once I stepped into there and started looking at models of behavior change, there's all kinds of good information about how do you work with somebody to get, and then it's like, oh, it's here.
Right.
And this is the positive side of change, right? So it's like there is alternatives.
Right.
And there are models that actually work really well and explain exactly what we're experiencing.
Right.
And so if we would just step in there and start learn
a little bit about that.
We could have a revolution.
Yeah.
Right? And so then I was like, okay, so why shouldn't I become about psychosocial? And then and then the promise seemed to provide a solution at the level of measurement. So you could, because one of the things in measurement that's interesting is everybody talks about it's boring, and it totally is. There is nothing interesting about measurement, except that if you put a measurement in front of a provider and say you're going to be measured on this at your follow-up. Like right now, we all hold ourselves accountable to physical function.
Right.
But if you also held yourself accountable for a psychosocial variable, all of a sudden every therapist would become about that psychosocial variable.
Right.
They'd be all about every aspect of version of dry needling about that. It's the same way they are about physical function.
Right.
And then all of a sudden we'd be multidimensional.
Right.
And so I thought, okay, well, measurement's good then. We should push measurement because it drives practice.
Okay, I like that. I like where you're going because I hadn't really thought of applying that model, another model, if you will, to these fringe treatments that are pervasive.
Because you won't have time. See, my idea is like, and not that I've read some things. I'm sure the dry needling that actually work. I know it's very popular.
No, it's true.
It
doesn't work any better than other treatments. It works as effective as exercise. So if you look at kind of the breadth of literature, it does work.
There's
for pain,
but
not any better than any of the other modalities.
Right.
Like
so
exercise.
I mean, it should be I mean, I'm not an expert in dry needling, so I shouldn't.
No, I know.
But I just
I've read enough to know.
Yeah.
I've not practiced it, but
right.
the literature is clear about how it works.
Okay.
Yeah.
So to me, it's more how we spend our time
right.
and what our focus is,
right.
and where we might have more opportunity.
Yeah.
And to me, the idea of bigger, better, biomedical treatments that are physical is good.
Yeah.
We should, keep
right,
focused on that.
Yeah.
And
bio is important.
it's important, right? But
biomechanics is still important in load.
And we just talked about organism and all that earlier, right? But at the same time, the bigger opportunity and where we lack a lot of depth and kind of complexity that our patients need us to be more adept at is the psychosocial part.
Yeah.
And so to me, that's more of the blue ocean, or the area where we could do more development and see a bigger gain in our just ability to manage patients. The verdict's probably still out on whether behavior change and all these things will make a big difference in our outcomes, right? But I think that it'll help us manage patients better, have more compliance with our home exercise programs and things like that.
Yeah.
And I also think, which is interesting, I didn't really think about this until we've done some of these educational seminars, is they actually make patients feel better about what they're, or not patients, providers, PTs,
without question,
about what they're doing, because they're not so frustrated. Because it's like, it's the most frustrating thing in the world. They just say, I'm only bio, I'm only bio, and you have a person in front of you that's actually a person that has emotions, that has all these feelings and things happening. Then no, I'm only the bio part. I can't deal, I can only deal from my, my own emotional experiences or psychology. That's all I can do. I don't have a strong psychological model to handle what you're experiencing. So I can only go so far, right? If you have skills, you can walk with patients really far into their experience. And really be okay with that. And then at the end of the day, feel good about just helping them with the emotional part, even though their bio may have stayed the same, but then they got going. You may have activated them by just talking to them differently and having a good understanding of the psychosocial aspect.
Well, it's clear it's a barrier, and we haven't addressed it for a long time.
Yeah, but I think what I'm trying to get is, like, I just had last night, one of our students was on a fill, and we were playing tennis, and she says to me how happy she was when she did a MI, motivational interviewing on a patient, and they said after the end of the clinic, they says, I feel so vibrant right now. And she said she felt so good. So I guess what I'm getting at is, like, when you're sharing more of, like, the emotions of a patient instead of just, like, how many reps did you do, how far did you walk on the treadmill, all these kind of physical goals, that your physical goals and, like, their emotional goals or whatever is happening, you're going to get both of those now if you do psychosocial. And so your experience as a provider will change from just documenting physical to actually help experiencing their psychosocial recoveries, where they're having gains in their satisfaction with social roles and their psychological balance. They're going to be sharing that with you because you're now partly responsible for that. And it feels different at the provider level because you feel like you're treating a whole person.
Contributed,
It's like a real dynamic process.
So that's promise.
That came from promise. I know. So that's what's weird. How does that come from measurement? It comes from measurement because if you're treating self-efficacy and you think you are, but you're not measuring it, you have no idea if it's actually working.
Not a clue.
And so what's going to happen is you're going to learn by measuring it, like, when you really, like, the things you think are happening, if they're really doing what you think they are. Because you get held accountable. It's the same way if you measure strength, because you want to change it and you're like, well, that didn't change. I must be missing something. It's the same thing. So promise gives you a way to check yourself and assure that you're doing psychologically informed PT, but you're not a psychologist, and you're not a social worker, and so are you hitting the marks? Are they going off the railroad tracks? Do you need to get help? Do you need to check and see what your strategy is? Things like that. So they give you a way of, like, being accountable, basically.
Well, and I think that's consistent with what we're measuring in the clinic, So you've taken a ton of that data and looking at it closely, and one of a few rural places that are providing lots of data for us to look at promise. And
so I'll just share one thing that we just put out a paper. fingers crossed, right?
Yeah.
But so people with low self-efficacy are 20 times more likely to have, 1, 2, or 3 different physical traits low than people who don't have low self-efficacy.
So physical traits meaning?
Physical function, pain, and fatigue.
Got it.
So when self-efficacy is low, things can be
So
really
low,
off the rail track.
Yeah, so like 1 standard deviation low. What's the cutoff-ish?
So like a half standard deviation is what we use.
A half standard deviation.
Below the U.S. norm.
Which would be 45.
Yeah.
So they score 45
or lower,
and they have 20 times more of a challenge with these other physical functions.
So that's a pretty big odds ratio.
Yeah.
I've never seen one that large. I've never done research and produced one that large.
Not in a biological system.
Nope.
Right.
So that's pretty powerful, right?
Yeah.
And so and then just to kind of flip side on that, some other.
How many patients was that?
That was 218.
Okay. Yeah.
At the initial physical therapy visit, right? So I mean, it's it's one thing you can talk about unpublished data, but hopefully it'll get published.
Right.
But I mean, the data we have right now, like a published paper, shows that self-efficacy is has the same predictive power of telling somebody who's acceptable symptoms and function as physical function.
Right.
Same exact accuracy in predicting who has unacceptable physical function.
So the PASS.
Just asking them.
PASS.
Yes.
Right.
But just asking them about self-efficacy.
Right.
So that's pretty powerful.
No, it is. I remember you and I talked about this in '96, maybe. I don't know. It was a long time ago. Where it was.
How do you remember that?
It was the SF-36. Remember?
Oh, yeah.
And then it went
right.
down to SF-6.
The Moss, remember, was the Moss 10.
Right, whatever it was. Yeah, it was
first.
this high number, and then 36 questions, and then 6 questions.
And then there was an SF-12, right?
And then there was we joked about this because I said, well, it should just be the SF-1. How do you think you're doing?
Yeah, right. That's right.
Because that's what you just said.
Right. That's the PASS score, right?
That or a self-efficacy.
Right.
So essentially, how do you feel that you could manage, your symptoms?
Right.
So in one question, you could figure it all out.
No, and I think there's good data. Like Kristen Archer, his group from Vanderbilt, just published a study this last couple months that shows that self-efficacy mediates recovery from chronic pain. Or mediates chronic pain responses in a controlled trial.
Right.
And that's consistent with another paper by Mary Jung from Vancouver that just put out this stuff on Small Steps for Big Changes program, where she showed that self-efficacy mediated participation in exercise.
So what would be a way? Would this be self-efficacy? So. Dan in our clinic, we have a very high percent of patients that are lacking of any health services, don't have health care.
Right.
It's a more socioeconomic deprived area of Yamhill County, and so he started texting people.
Yeah. This is great.
And so. He asks them if he could follow up with them tomorrow or the next day via text.
So actually, I love the way he approaches this because I asked anyway. Without getting into my dad's having some health issues, so I asked him yesterday the same way that Dan asks people. Right? You just say, "How can I support you?"
Right.
And then they they fumble around at first.
Right.
So how else can I support you? And then because they say. They don't know what to say because they're afraid to ask you for more.
Right.
And then you have to kind of give them permission, right? And so my dad just agreed to have me call him every day and talk about his step count, right? Because he wants me to do that. And but that's what patients... They love it.
No, I know. That was the story I was going to. So Dan says, "Can I call you or can I text you? Can I follow up?"
But I wanted people to know it's more general. It's like, how can I support you?
Right.
And then it ends up on, hey, you can call me because they don't want you to come visit them because that's too invasive. And it's like they don't want an exercise program.
No, at all.
They can do that themselves.
Right.
But they do want some connection with you.
Right.
And that's what they're kind of in their way. They're going to ask for that, right? And so...
No, I love the story because I don't know if we talked about it when Dan was here, but, so he calls and this person's grumpy. Why are you calling me?
Right, exactly.
Right? Well, because you asked that I call you.
Right.
Oh, yeah.
Mm-hmm.
Then, so it wasn't badgering.
Mm-mm.
So on the next week, oh, yeah, I did my exercises all week long.
And I appreciate, and will you call me again?
Yes.
And that's how it goes, right?
So,
it's,
so that's at some level addressing self-efficacy.
Yes.
So that's weird to me, right? Because you're not you're
well, but there's two types.
Because we're not necessarily psychologists, but we're in that domain by addressing these barriers that are not physical.
So the question is if we understood like what I'm going to, there is some issues. If we understood more psychological theory and framework, we would understand how that, what part of self-efficacy does address.
Jeff is selling me on this. So it's been 4 years. I bought in early.
But then he's resistant.
And then I'm not resistant, but...
Oh, yes, you are. Yes, you are. You're bio. He's like, but
no, I'm
skeptic. You're a skeptic.
No, I wasn't. No, not a skeptic at all.
Okay.
So here's where now it's my turn. So this is where I went since you lobbed out that.
I did.
Because our early data on self-efficacy, we didn't address it one bit. We didn't say we're psychologists. We didn't go into this frame about now let's address these barriers that are non-physical because we measured it. Right. But they got better.
Right.
And so that's to me it was super compelling where their points were out of control with self-efficacy when we just met them and asked them to move.
Right. So that was in. So it's it. So I understand where you're coming from because you're thinking. So we don't really need specialized training because we're already doing it as a consequence of our interactions with patients. And this has come up in some of the 50-50 lectures that we do for Beyond Biopsychosocial. Yeah. And what's interesting is this. So
I'm not resistant at all because you sold me on the patient-reported outcome and knowing what to actually do as a therapist in treatment because now we know what's wrong.
Right.
We know what's the biggest barrier to them, whether it be pain or physical function or self-efficacy or whatever that might be.
So what I hear you saying is the documentation.
I was like that. So I hear you saying motivational engineering, by the way.
It's true. It's true. But I just being listened to is good, right? So is that the importance of self-efficacy is there, but how to address it is the open question.
Yeah, because I think there's lots of ways.
Correct.
Instead of turning ourselves into a psychologist, you're not suggesting that. So early on, he was suggesting that. So he's actually changed. So
no, I'm even more about it now than ever. Here's an example. So there's two different types of self-efficacy is task specific.
Sure, it is.
Okay, so there's
it's
specific to a bunch of stuff. Right?
It is right.
So we do task self-efficacy pretty well, probably. Which is, hey, here's what you can do. Let me show you how you can do this exercise, or challenge yourself in a task. But there's something different called regulatory efficacy. So it's efficacy in your ability to modulate, participation in things and things like that. Right. So see, when you do the callbacks, we're not doing task self-efficacy.
Right.
We're addressing regulatory efficacy, their ability to kind of manage all the other competing interests in their life and prioritize on these things that are going to make them better.
Right.
Okay, so the models help us understand how to build a program that deals with different elements of a patient's psychosocial experience.
Right.
And so the benefit to getting into psychological theory is that it becomes much more purposeful for what our activities are.
But here's the challenges too, meaning I think some of the resistance maybe is now I have to address their self-efficacy.
Yes.
And we're not.
Correct.
We're indirectly addressing their stuff.
We have to think about it.
So that's what I like about it.
Yeah.
Because that's what we're actually doing. Mm-hmm. Because we're not psychologists, so we're not actually asking them about how we can fix their self-efficacy. We're using, like you said, these other models to help us address these things that show up on the promise.
So what if we're wasting time, though, on task self-efficacy, and we should be spending time on regulatory efficacy, and we could do everything we're doing in less treatments? See, I'm all about less treatment because I want...
You know me, that primary care switched us.
I know, right, because essentially if we're doing public health, our magic,
you got one shot.
Yeah, exactly. We have to do more with less,
Yep.
right? And so how do you do that? You have a very intentional treatment that doesn't require comebacks, that they're really much more independent and working at their own rates, at their own levels, without our optimal program, but their optimal program for them. It's wherever they're at. Yeah. And then basically we're treating way more people because we're only touching people 1 to 4 times maybe. Right. And that's our really high end.
4 is our high. Yeah.
Right. And we have effective treatments within that range. Right. That would be, because my basic goal is to have no PT have every single PT feel like counting reps is below them.
Well, I would hope that we're getting that across to our students anyway. Right. That is not the top of our license to sit and watch someone count reps.
No. It is not, right? I mean, you get paid way too much, and we have too much value. Right. And not that you can't do menial things. I mean, it's like...
Oh, sure. Like incorporate it as part of your
what you're doing and things like that. But I think we can find other ways to spend our time.
And have value to the population.
Yeah. And I think that's what we should be doing, right? Yeah. Anyway, we had an hour?
I don't know. How much time?
Yeah, we're way over that.
Are we?
That's great.
All right, then that's it.
I know, right?
Leave us with a few nuggets that we can take away for the PTs to put into practice. Like, I don't know, you ask the question, like create your own question of like...
So pause, so you can cut.
Okay.
Perfect. We got the sound on.
So how can we implement as a therapist, in a clinic? How can we implement some of these? And I don't know. Let's pick. If it's taken you 4 years of all in with Promise to kind of get where you're at, right? And so that's not going to happen in practice.
Oh, for people to also spend 4 years.
Yeah, it's not going to happen. So how can we? Yeah. So what 3 things or 2 or how can we focus our attention in clinic for therapists that might be listening or our alumni, even our students or whoever's listening? How can we be better at understanding self-efficacy or these psychosocial domains that we're not really, specifically addressing?
Well, the first thing I'd just say is just start taking. There's all kinds of courses on ACT, social cognitive theory, behavior change. Just take your pick. Doesn't matter. Okay. You can do CBF, cognitive behavioral therapy. Yeah. You can do, focused acceptance commitment theory.
Right. Fact.
Yeah. You can do, psychological course. Just take some. Right. They're all available. I'm going to ask you for $250 to do my own coming up. It's a combination of ACT and CBT. Right. And they sound like they have nothing to do with PT, but just do them and trust in providence. Right. You will find ways to implement them clinically. Right. And so that would be the first thing, because it's like I find that the psychologically informed things that are going on for us are kind of 2-dimensional, and when you met a real person, they need a 3-dimensional treatment. So you need something more effective. You need basic counseling skills to be able to talk to patients, right? Yep. So that's what I would do, is just get better. And even if those are scary, and whatever motivational interviewing you've had, I 100% guarantee it's not good enough. Right. And so go take another course on motivational interviewing and get better at it. Right. Because basically the better you get at it, that's the basic skill that you need to start talking to people and understanding how to get at things that you're not getting at now. Right. And trust me, if you think you have a good psychosocial framework, you probably don't. Right. Right. And so that's just that'd be number 1. And then, number 2 would be start asking the question is how many visits do you have total on your averages? And could you, what would it take for you to reduce those? And how could you treat patients in a way that they get more compliance on their own? So if you became refocused on patients doing things on their own, 100% first. Yep. And second, on things you could do in the clinic, see what happens to your patient problem solving. Right. It'll change, right? And of course, I like that. Yeah. There's a lot of post-op that you still want to see patients, right? I mean, that's not the point, you know. But there's
we need to see more of the population.
I mean, one of the things I'd say about that is when we had co-pays in New York when I was treating there, because I had a pretty active clinic practice. and the co-pays in New York were $50 a visit.
Right.
And so I found ways to manage, post-op care one time a week, because patients didn't want to pay and they wanted treatment over the whole span of their recovery.
Of their care,
and they couldn't afford it, right? And so 3 times a week was basically they're going to get 2 weeks of treatment, and then they're going to be out of money, right? So essentially we spread it out over 12 weeks, and they loved it. And we would have, but I would have them buy, like for them it became financially better for them to buy equipment to make a gym at home that they could function with. And so there's lots of great ways you can get patients to be more independent with what they're doing.
Right.
Now, we actually had those patients, I would see them for like an hour and a half on their one-time visit, because we wanted to cover a lot of ground, a lot of evaluation, a lot of new discovery in terms of things that they could do that they couldn't do the last week, things like that. But it was super fun because the patients were really zeroed in on the goals, because they were really motivated not to come in every week, and I was motivated to make sure it was worth their $50 to come in. And so every week the goal was to make sure that they saw a change. So they had to have and they would come in, and then also to give them something new, a new goal that was substantial, so that they would really
have to focus on it.
That's right. And so they were laser focused. And so what was super interesting is the first thing that happened every time they would come in and show me all the things they had accomplished.
Right.
It was amazing. Right. It was a completely different way of interacting with people, and it was really fun.
Yeah.
And so I would say explore these options because
options. That's good.
And then the last thing I would say is stop trying to be perfect, because there's this sense that if you can't make patients 100% perfect in everything that's happening, then you're not a good therapist and you left something on the table for them. But recognizing that we're organisms, and basically we don't really function perfectly. We function with imbalances, and all of these, scapular dyskinesia is nearly as normal in people without shoulder pain as with shoulder pain. So how important is it to eradicate that?
It's not.
Right. And so I think getting this new frame on, embrace it 100%, and stop being so focused on these kind of tangents, and stay focused on health as a primary goal of therapy. Those would be the 3 I would give. What's your 3?
Those are great 3. I'm just going to add 1. Don't forget the bio.
Oh, right. No, for sure.
So, because I think what's happening, with kind of this surge, if you will, this kind of this idea that, it's more important than we once thought.
Yes.
So,
yes.
And it's been clear, and it's becoming more clear that it's a barrier for population health, and but at the same time, there's a lot of bio.
Mm-hmm. And then there's still people that have a rotator cuff tear. That's bio. And
diabetes is bio. Obesity is bio. Heart disease is bio.
Yeah.
Right. So, but and those are the population things that we can hopefully affect. So.
Yeah.
Cool.
I love it.
Thanks, Jeff.
Yep.
That was awesome.
No, that's good. Was it good?
Yeah.
That was.
Wow. Great topic today. Great conversation today. Thanks for listening. Thanks for tuning in. And just make sure you're connecting with us in some way, whether it would be liking or subscribing. You can connect with us directly, and be sure to visit our website, motifcenter.com. And if you want to be featured in our Q&A, send us a question. We'll be happy to answer that in our Q&A session, and let us know where you're coming from.